the United States, respectively. So would you, Professor Dogmichi, would you please start?
Professor Dogmichi, you are mute.
Yeah, okay. Thank you very much, Mr. President. The first speaker, Professor Cruz Paras Aital, he graduated from Kasturba Medical College in India in 1986, and he moved to United Kingdom in 1993. He had worked at several hospitals, including Royal College and University of Newcastle. Currently, he has been working at University of Nottingham as professor of hepatology. He gained many grants and more than 20 awards. He has in total almost 300 publications, including 176 original articles. He is the member of several committees and associations. Also, his personal interests are theater and photography. Yes, Professor Aital.
Thank you very much for the introduction. I'll be talking about algorithmic approach to the management of ascites in cirrhosis. Just to highlight that the approach should be evidence-based, and evidence, most robust evidence assumed to be efficacy demonstrated by randomized controlled trials. But there are levels of efficacy beyond that. Randomized controlled trials are designed for a robustness, for the quality of its ability to answer the questions that is asked. When it comes into clinical practice, wider group of people who are not included in the randomized controlled trial do get into the interventions or treatments, exposed to medications. So effectiveness in real life is the next level of evidence one gets about any intervention. And then in a health service, which is either delivered by public health or where the patient pays for the treatment, cost effectiveness determines really how many people get to have the intervention. So cost effectiveness is still...
Sorry,
Professor Aital, we cannot see your slides. Please share your slides.
Can you share your slide, please?
Oh, I'll have to go back then. Sorry, I had it on the screen before the talk started.
Would you please stop it and stop sharing and share it again?
Okay. Okay. Now it's unshared, right? Okay. Can you see it now?
Yes.
Yes, it's starting.
Yes?
It's starting. Okay.
Starting.
Okay. So I was just talking about the levels of evidence. Even most people will assume that efficacy, demonstration of efficacy of an intervention through a randomized controlled trial is a good evidence. Of course, it's a high quality evidence, but it's not sufficient, because when you bring any intervention into clinical practice, naturally, people who aren't really included within the limitations of efficacy-focused randomized clinical trial will get exposed to the intervention. In real life, more people who may not strictly meet the criteria where it was tested in randomized controlled trial get exposed to the intervention. So effectiveness is the next level of evidence, which is coming from real life clinical practice, is important. And then in public health, where interventions or healthcare is delivered through as a public service, or even when it's a private service where patients pay for an intervention, cost effectiveness is the highest level of evidence, because one need to be able to afford the treatment. Then only it really makes a difference in a population. So I will go through an algorithmic approach to different key interventions in ascites, and talk through what level of evidence there is and where the source of evidence comes from in this presentation. This is the mechanism of how ascites is formed. First of all, portal hypertension is the most important starting point for formation of ascites. There is clearly raised intrahepatic resistance and increased portal flow. Two of these factors are key to development of portal hypertension. And when the portal hypertension stimulates endothelia within the portal circulation, angiogenic practice, both neoangiogenic factors as well as chemokines, the cytokines get liberated by the endothelium, which is stressed and exposed to shear stress. So you have both formation of portosystemic collaterals as well as circulation of vasodilators, which are trying to open up these collaterals. Now, through portosystemic collaterals, enter the systemic circulation. This results in reduced both splanchnic as well as systemic vascular resistance. That results in effective hypovolemia. So reduced arterial blood volume, or sensed as an effective hypovolemia by the system, is one of the key trigger to generation of activation of vasoconstrictor neurohumoral systems. So these work at 3 levels. Renin-angiotensin-aldosterone works through distal tubules and collecting ducts. Sympathetic nervous system acts through the whole of the renal system, and antidiuretic hormone works through the collecting ducts. And overall, there is a retention of salt and water. So if one can highlight 2 key steps in the development of ascites, one is portal hypertension development, and the second one is renal salt and water retention. So management has to be focused on different phases of it. So the first step is to really reduce salt and water retention. This is done through the introduction of diuretics. And if you look at randomized controlled trials, the initial randomized controlled trials were testing stepwise introduction of diuretics. More recent randomized controlled trial is identifying whether combination of both potassium sparing diuretics, which is really true aldosterone antagonist, as well as combination of loop diuretic, is better way forward. And the results on the surface of it look like they are conflicting. So initial studies showed that step up approach, in other words, start with spironolactone, because the key mediator of salt and water retention is extra aldosterone secretion. So aldosterone antagonist looks like the reasonable logical step, and increase it to highest dose as seen in this part, and then introducing furosemide looks like a logical approach. And it showed initially in a randomized controlled trial this to be the effective way of introducing diuretics. But more recent study led by Angeli shows that a combination therapy is really the one which results in diuresis much earlier, almost like within 2 weeks, the optimum diuretic is achieved. And it also reduces overall electrolyte imbalance with the 2 kinds of diuretics. So spironolactone obviously acts on the pathogenetic pathway, while furosemide, loop diuretic, is much more potent and adds as an adjunct, resulting in a higher diuresis. So what I would do is really, if the patient presents very early, first time you see them, they've got mild ascites and they haven't been exposed to any medication, Then I follow stepwise approach. I start with spironolactone and then introduce furosemide. But I don't wait till spironolactone is reached to 400 because by then they might have some of the adverse effects of spironolactone. If the patient comes with moderate or large ascites and they have already been exposed to some medication by the GP, then I would really use combination therapy and then increase both drugs, spironolactone starting with 100 milligrams, furosemide 40 milligrams, and then increase spironolactone doubling as well as furosemide doubling together to reach the highest threshold. Generally in the literature, the maximum point is 400 milligrams of spironolactone and 160 milligrams of furosemide, but in reality, very, very few patients reach that threshold, at least in the population that I treat. Most of them either get adverse effects and have to really change the strategy. How do you monitor them? You try and, as long as there is fluid retention elsewhere, in other words, if the patient has got edema, then there shouldn't be too much worry about the upper limit of weight loss. It is that you do manifest with a weight loss is all you need to really see. If there is no edema, or once edema disappears, then one need to be more careful, and then I aim for 0.5 kilogram weight loss per day in those patients. If patients are not responding to diuretics, then sometimes I check for compliance. The logic is that generally you have restricted patient salt intake. General advice is to really reduce salt intake, at least avoid added salt. Too much reduction in salt intake will make the food unpalatable. So you would really ask them to cook with salt as they like it, so that eating is very important, but try and avoid added salt. So generally, salt intake will be about 88 millimoles per day in this kind of advice if they are compliant. And there's about 10 millimoles of non-urinary excretion of sodium. So you want to see at least more than 78 millimoles of sodium excretion per day. So if you have a doubt about the compliance, you can do a SNAP sodium potassium ratio. If it is between 1.8 to 2.5, then it has got about 70 to 85% accuracy to say that patient is excreting about 78 millimoles of salt per day. And if there are adverse events, obviously you need to change, reduce the dose, or stop diuretic completely. And ideally, you would like to achieve resolution of ascites, which is possible in reversible conditions such as alcoholic liver disease if they are abstinent, and also you start diuretics. In small proportion of patients, you can resolve ascites just using diuretics. And when diuretics either become refractory to the treatment, which can be either intolerance to diuretic adverse effects, or you reach a maximum diuretic dose and you still don't really achieve the weight loss, then you call it refractory ascites. This is a standard indication for therapeutic paracentesis. And however, there are a number of patients who end up in hospital because of symptoms, and you may end up having to do therapeutic paracentesis as an inpatient on an urgent basis if they are breathless, and when they're admitted with additional problems, but you feel that their food intake is reduced substantially because of ascites, or you can't send patients home because of the reduced mobility, because of the weight they're carrying with ascites, or it's causing significant pain because of a tense ascites, you may end up in doing therapeutic paracentesis. Occasionally, when umbilical hernia is reducible, again, to really start treatment in an inpatient and get them home fairly quickly, you might end up in doing a therapeutic paracentesis. But most common indication is refractory ascites, and the system is really set up through day case unit so that they don't need to get admitted. The link is established between the day case unit staff and the patients, and patients are monitoring their weight at home. And on an average, when they gain about 8 kilograms, they are brought preemptively to day case unit and they get therapeutic paracentesis so that they don't end up in acute services or emergency hospital admission. In some patients who are deemed not suitable for transplantation, this can be the final treatment where they kind of come regularly as they feel necessary and then get therapeutic paracentesis. So what's the evidence for this kind of algorithm for therapeutic paracentesis? This is the most up-to-date systematic review and a meta-analysis that was performed when we drew up Ascites guidelines for British Society of Gastroenterology. It included 19 studies out of 27 that were performed. 6 were excluded because of particular data, and 2 were excluded because of partial reporting. So overall 19 studies were included. All we did was to therapeutic paracentesis plus human albumin solution versus alternative control group. Either these were no other interventions as a comparator. These studies happened very early on in 1993, one, and then one study in 2018, or with alternative plasma expander or with the vasoconstrictor. So the hard outcome, if you look at overall survival benefit, was seen. You can see here 23% reduction in mortality in people who are receiving therapeutic paracentesis plus salt porous albumin was seen. This is just significant. Its confidence interval is 0.59 to 1. Interestingly, although 20% albumin infusion with therapeutic paracentesis was started as a way of reducing post-paracentesis circulatory dysfunction as manifesting as renal dysfunction, this meta-analysis did not show there was a statistically significant benefit in reducing renal dysfunction by giving albumin paracentesis. You can see the odds ratio is similar, 0.77, but confidence interval is crossing 1, which means that it's not significant. So mechanism by which 20% albumin, in addition to therapeutic paracentesis, reduces mortality is still unclear. And if the patient has got hospitalization from ascites, most important factor to really avoid is to miss in diagnosis of spontaneous bacterial peritonitis. Incidence of spontaneous bacterial peritonitis is variable, anywhere between 10% to 23% in different cohorts. It's important that these are diagnosed in patients in hospital who are hospitalized, whichever way they came into hospital, because its incidence seemed to be nearly threefold compared to its incidence in outpatient with ascites. So the rule is that you need to do diagnostic paracentesis as soon as possible within 24 hours. If you don't, just delayed diagnosis in one of the studies shown to have increased mortality by 3.3% for every hour of delay. It's just one center study. So diagnosis of SPSP is based on neutrophil count more than 250 cells per cubic millimeter or more than 500 total white count for the same volume. And this is because their performance characteristics are fairly similar. I'm sorry, this should be 10 to the power 0.5, 10 to the power 9 per liter. If they have got raised creatinine, then I would give, in addition, human salt porous albumin. If they don't have raised creatinine, just give antibiotics. We do not recommend that there should be one universal antibiotic recommended for the worldwide population. This should be decided by the local clinicians based on the microbiology results of the local population, what antibiotic resistance there are, and what is the affordability of what antibiotic which are effective. If the patient has got significant pain, which is localized, or tenderness, very high white counts in thousands of neutrophils or total count, or signs of systemic sepsis in addition to SBP diagnosis, or if they fail to respond to within 2 days for antibiotic, then you may need to think of secondary bacterial peritonitis, which is a localized collection or perforation, which is resulting in peritonitis. So CT scan is indicated. And if they have got spontaneous bacterial peritonitis with raised creatinine, then here is the evidence to show that addition of 20% albumin infusion reduces mortality by almost like 47%. This is statistically significant. And earlier you do the therapeutic, diagnostic paracentesis, better is the outcome. This is the study that I quoted. We showed that in-hospital mortality was substantially lower. It also showed that there is significant gain in 3 months mortality earlier you diagnose. It reduces intensive care days, reduces hospital days, but it did not really have any effect on 1 year survival. So early diagnosis of spontaneous bacterial peritonitis and addition of albumin when creatinine is elevation is the next intervention which is important in patients with ascites. The next intervention when therapeutic paracentesis is not suitable or becomes a problem. So there are 2 primary indications for TIPS. One of them is really refractory ascites, which is standard, and you need to choose patients suitable for transjugular intrahepatic portosystemic stent shunt. The second indication is coming up more recently. I'll tell you why this is an important indication. This is recurrent ascites requiring frequent therapeutic paracentesis. And this is coming from one randomized controlled trial, but that is because the outcome of transjugular intrahepatic portosystemic stent shunt seem to be getting better with the advent of covered stent. So if people have had also more than 2 or equal to 2 hospital admissions just for ascites alone, again, TIPS can be considered. But there are some potential complications of TIPS. Most common is encephalopathy, which is more common in people with the age over 70 years. Obviously, people with recurrent overt encephalopathy, especially those without precipitating factor like GI bleed or infection, are particularly, one should be cautious about it. And bilirubin more than 100 is seen as a contraindication. More than 50 should be seen with caution. Those who have got Child-Pugh score more than 12 or MELD for more than 18 have got a poor outcome from TIPS insertion. Those who have got creatinine over 250 again might have a poor outcome. Hepatorenal syndrome type of AKI has been seen as a contraindication, although previously type 2 hepatorenal syndrome, there have been a couple of publications which suggested that it might be actually the potential intervention. And obviously, people with active infection, one need to treat them adequately before introducing TIPS. Refractory ascites, this is where the evidence comes from. There are 6 RCTs, 390 people, where TIPS is compared to paracentesis. And these were all derived from mainly bare stents. It did show, this meta-analysis did show, transplant-free survival was in favor of TIPS. And it also reduced liver-related deaths. But this was at the expense of increased hepatic encephalopathy. This is a randomized controlled trial that I cited, where this was a single center covered TIPS insertion for recurrent ascites, more than 2 or 2 large volume paracentesis within the 3 weeks. And they put in 10 millimeter covered stent, they dilated it, and then saw that HVPG is less than 12 millimeter after insertion, and they demonstrated survival benefit without increased transplant without increase in hepatic encephalopathy rate. So this is the only study there is. I talked about effectiveness, and this is the effectiveness study for TIPS. This is coming from UNOS, includes nearly 100,000 population who are investigated. And if you look at number of factors which were associated with improved survival, TIPS insertion for ascites comes as significant. So people who had TIPS were associated with reduced risk of death and reduced risk of death and transplantation. So there is some effectiveness data for TIPS. And then finally coming to cost effectiveness. Cost effectiveness is determined by what's called an incremental cost effectiveness ratio. This is a data that derived from quality adjusted life years, which is a combined parameter, includes both quality as well as a length of survival. So for example, one quality means that 1 year of perfect health. So if you kind of compare the two treatments and divide it by quality adjusted life years between two treatments, then you get what's called ICER. And you get what is called a willingness to pay threshold. This is a diagonal. And if the treatment falls below this diagonal, then it is really deemed cost effective. And here is the cost effectiveness study that we performed. You can see in the table above that plasma large volume paracentesis with salt per albumin costs about 25,285 pounds per quality adjusted life year saved. In UK, 20,000, this line 20,000 is seen as a threshold. While TIPS, most of the dots, this is about 10,000 dots here, fall below this line, which means that there is almost like 100% guarantee that TIPS is cost saving, not only cost effective, it's actually cost saving. So TIPS has got data of reduced mortality, effectiveness, as well as cost effectiveness. So whenever possible, you need to consider patient for TIPS when they have got recurrent paracentesis. Finally, long-term abdominal drainage for palliation. This is a tunnel through which drainage is put in. There is a feasibility randomized control trial which suggests reduced requirement of paracentesis as well as the cost, but this is just a feasibility study. It was associated with higher cellulitis rate, but the authors said that this was overcome by prophylactic antibiotic. But currently there is a randomized control trial ongoing to test the cost effectiveness of palliative paracentesis. So we need to wait for the results of the trial to really decide whether it is effective or cost effective. So these are the key references. This is a guidelines, British Society of Guidelines, published last year in Gut, as well as a blog associated with it to go through the presentation and sources of evidence for what I have presented today. Thank you very much.
Thank you very much, Professor Edo, for a very comprehensive management on cirrhotic ascites. So just to remind the audience that if you have questions, please do so. You can type your questions at the Q&A at the bottom of the chat. So the next speaker is Professor Richard Sterling. Professor Sterling is now Professor of Medicine and Section Chief of Hepatology at Virginia Commonwealth University. He also medical director of viral hepatitis. Professor Sterling has published over 230 manuscripts and many chapters. And he also serves at several prominent committees of National Association. Today, he's going to share with us on the algorithm for the management of hepatic hydrothorax. And after Professor Sterling lectures, we're going to have Q&A after his lecture. Professor Sterling, please.
Can you all hear me?
Yes, please.
Yes, we can hear you.
Okay. All right, good morning. It's 6 o'clock in the morning here. So let me just all right. So it's a pleasure to talk to you all today. Let me get my screen going here. On my algorithmic approach to the management of hepatic hydrothorax. So what we're going to talk about over the next 20 to 30 minutes is to understand the epidemiology of hepatic hydrothorax, the pathophysiology, how to make the diagnosis, and most importantly, how to manage it. So we'll start off with the case. It's a 54-year-old male with a history of alcoholic cirrhosis. He's had ascites for at least the last 6 months, and he's been managed with Lasix 40 milligrams a day and spironolactone 100 milligrams a day. His upper endoscopy showed small varices. His MELD is 14, and he comes to clinic today complaining of increasing shortness of breath and a non-productive cough. His last alcohol use was 8 months ago. So chest X-ray is performed and is shown here, and as you can see on the right side, he has a significant wide out and opacity consistent with a hepatic hydrothorax. So when we talk about complications of cirrhosis, which was talked about by the previous speaker, we certainly know things about hepatic encephalopathy, esophageal varices. We just heard about ascites, hepatorenal syndrome's effect on the kidneys, sarcopenia, and muscle wasting. But what we're going to focus on today is the pulmonary complications, and they're listed there as hepatopulmonary syndrome, portal pulmonary hypertension, and of course, what we're talking about today is hepatic hydrothorax. And each of these can often present with shortness of breath, but they have different pathophysiology and completely different management. So talking about hepatic hydrothorax, it's defined as the presence of a pleural effusion of at least 500 milliliters in the setting of cirrhosis without evidence of other cardiopulmonary diseases, and that's important. It's fairly common, a prevalence of 5 to 15% of patients with cirrhosis and portal hypertension. And keep in mind that about 20% of patients with hepatic hydrothorax can have no obvious ascites on exam. The presentation really depends on the amount of fluid. So what we typically look for are shortness of breath or dyspnea, which can occur in about a third. Cough occurs in 22%. Nausea can be the complaint in 11%. Pain, particularly in the right side of the chest, about 8%. But often it's just found on incidental imaging, and despite having a significant amount of fluid, patient really is relatively asymptomatic. It's important, however, when someone has a pleural effusion in the setting of cirrhosis, that we need to differentiate it from spontaneous bacterial pleuritis, which is very similar to SBP for ascites, but this is in the chest, parapneumonic effusion, and empyema. So in talking about the pathophysiology, it's explained here. And with portal hypertension, you get vasodilatation of the splenic and systemic arterial circulation. That leads to neural hormonal activation. You then get decreased sodium and water excretion, and that leads to ascites, which we've just heard about. But in select patients, you then get diaphragmatic defects, and the negative pressure of breathing then leads to some of that ascitic fluid, whether it's clinically evident or not, being displaced or sucked up into the chest. When you look at the transmigration of pleural fluid, it's typically on the right side about 73% of the time, but it can also be on the left side in 17% of the time, and it can be on both sides in about 10%. So a left-sided pleural effusion is unusual for hepatic hydrothorax, but it can occur. When you look at the type of diaphragmatic defects, there are 4 types shown here on this slide. Type 1 is when there's no obvious defect, and that occurs between 9 and 32% of the time. Blebs, which is a type 2 defect, is more common and occurs in 36 to 41% of the time. Fenestrations, which is perhaps the most common, type 3, can occur in up to 72%. Or gaps, which fall into none of the other categories, is the least common and can occur in 2 to 9% of the time. As I mentioned, most hepatic hydrothorax are on the right side compared to the left side or both. And again, typically that's because the right side of the diaphragm is also thinner than the left side. So when you have some of these defects, that's where the fluid, it has its pathway of least resistance. When we evaluate patients with hepatic hydrothorax, the first thing to do is to confirm cirrhosis or portal hypertension if that's not already been done. And we typically do that with blood work. And we start with an ultrasound with Doppler, which usually typically shows a cirrhotic or a nodular liver. It's important to make sure that you exclude cardiopulmonary disease because that's required to make the diagnosis of pure hepatic hydrothorax. And typically that's done with echo and chest CT, make sure you're not missing a mass or something else. And then it's important to sample the fluid, and there we do a thoracentesis. And when you get the fluid, we check it for cell count with differential, protein, albumin, just like we would do with the Ascites. But again, because we want to make sure we're not dealing with an infection, we need to check it for glucose, LDH. Unlike Ascites fluid, here in the pleural space, we check the pH, and then of course we send it off for culture. Cultures should be done very similar to the way you do Ascites fluid with injecting the fluid directly into the blood culture bottle if possible. So this slide shows the differential diagnosis between hepatic hydrothorax and the other types of fluid that can accumulate, including the spontaneous bacterial pleural infection, a uncomplicated or complicated pneumonic infusion, and of course an empyema. So again, with hepatic hydrothorax, you have portal hypertension and it's not infected. The type of fluid typically is transudate, and as you can see, as you go across to the infected types of fluids, those are typically more exudative, and empyema would be purulent. pH for hepatic hydrothorax is greater than 7.3, and as you can see, that's the same for SB PL and an uncomplicated pneumonic effusion. But once you get infection, complicated empyema, the pH drops to less than 7.2. Typically, glucoses are greater than 60. Again, as you get infection, they drop to less than 40. Here, we do a fluid to serum protein ratio. Typically, it should be less than 0.5 in hepatic hydrothorax. And once it gets to a complicated pneumonic effusion or empyema, that ratio goes to greater than 0.5. Typically, LDHs are low, whereas when once it gets infected, it becomes quite high, and even can be over up to 1,000. The fluid to serum LDH is typically less than 0.6 in hepatic hydrothorax, where once it gets infected, that ratio gets greater than 0.6. You have a serum to ascites albumin gradient of greater than 1.1, very similar to ascites. And of course, it's culture negative in hepatic hydrothorax, where if it's infected, it's going to be positive. So this table can be very helpful in trying to differentiate the type of fluid you have, as long as you have all of the components. When we look at the impact of outcomes of having hepatic hydrothorax, that's shown by this slide that was published in Journal of Clinical Medicine in 2021. And as you can see in the green bars, people who have the hepatic hydrothorax, yes, have a lower cumulative survival than someone who doesn't have hepatic hydrothorax. So it's important to keep in mind that just having it, just like having ascites, impacts your outcomes. When this was a study that was published just this year in DDS that compares the outcomes of hepatic hydrothorax to those with sort of a matched ascites control group, just to compare the difference. And so there were 47 patients in each group. You can see they were relatively matched for age, sex, and median MELD. Sodium was both low, below 20. More people in the hepatic hydrothorax group had hepatocellular carcinoma, and they were slightly less likely to have alcohol. The doses of diuretics were pretty much the same between both groups. But as you can see, the 1-year mortality was 51% and significantly higher than those who just had ascites alone. And that's if the MELD on this group was less than 20, the hazard ratio for survival was 0.39. which was highly significant. So again, having hepatic hydrothorax is sort of worse for outcomes if you adjust for other things than just having ascites alone. And you can see the median survival was less than a year in the hepatic hydrothorax group, where it was greater than 1 year in this otherwise compensated cirrhotic group with just ascites alone. So this is my algorithmic approach, and this came from the article that I published in Hepatology in 2020, and we're going to come back to this. So as you can see here, you have the hepatic hydrothorax. You start with, just like ascites, you start with low sodium diet, hopefully less than 2 grams of sodium per day. If it works, great, but if it doesn't, then you have to maintain and check to see if the patient is on the appropriate dose of diuretics. Here again, I usually check for a spot urine sodium and potassium, and I like to see the urine sodium greater than the potassium as long as the patient is tolerating the diuretics and hasn't dropped their sodium or increased their creatinine. However, it's important to remember that once someone has hepatic hydrothorax, just like if they have ascites, even if their MEL score doesn't meet our minimal listing criteria, which in the US is 15, those are patients that you need to start thinking about liver transplant. So it's important to keep in mind that ask, is the patient going to be a liver transplant candidate? If the answer is yes, and they have a very short waiting time, you can just continue to do periodic thoracentesis. However, if not, then then you need to consider TIPS, much like we heard in the last talk. If it improves with TIPS, that's great. If it doesn't, then there might be some potential surgical options, and we're going to go over them. If the patient is not a TIPS candidate and not a surgical candidate, then I think it's important to think about palliative measures, which could be either repeating a thoracentesis or perhaps placing another type of catheter like a Pluridex. So when we talk about medical therapy similar to management of ascites, it starts with diet and diuretics. Again, the diet should be a 2 gram of sodium diet. Diuretics, we typically start with 40 milligrams of Lasix orally and 100 milligrams of spironolactone orally taken both at the same time each day. We call that step 1, at least in the US. Those can then be increased in a stepwise fashion to a maximum of 400 milligrams of spironolactone and 160 milligrams of Lasix. The goal here is to decrease the weight about up to 1 kilogram per day and to monitor the electrolytes. Particularly, you're looking for urine sodium greater than urine potassium. If you see a sodium greater than potassium urine spot ratio greater than 1 and the patient has recurrent fluid, then it's probably the patient's diuretics, and the diet and increasing the diuretics are probably not going to help all that much. While additions to this, including octreotide, terlipressin, midodrine, and albumin, have been used, most of them are unproven and not helpful. So next, we just heard a little bit about TIPS, so I won't go into too many details because you all are familiar with it. But here, the criteria for TIPS in hepatic hydrothorax is you must have portal hypertension, which again is defined as greater than 12 millimeters of mercury of the HVPG. You don't want to have a contraindication, so you want to have a MEL that's less than 18 or certainly less than 20. Again, it's important to rule out cardiopulmonary disease, so an echo is done and you'd like to see an EF of at least 50%, no evidence of pulmonary hypertension, and importantly, no significant valvular disease, including things like TR. Patients should have no significant hepatic encephalopathy, no portal vein thrombosis, and they should have kidneys that work and shouldn't be on hemodialysis. So once you've decided to place the TIPS, you can expect the outcomes that about 73 to 82% will have improvement. Complete improvement can occur in up to 71%, where a partial is at 17%. However, TIPS is not without its own complications, and about a quarter can develop encephalopathy. And again, the 1 year survival with TIPS is better than without it at 60 to 70%. But again, it's important to realize that liver transplant ultimately may be their best long-term outcome. So some other things that you can try is to prevent the transfer of fluid, and that can be done in a couple ways. One is just trying the patient on continuous positive airway pressure, or CPAP. It's relatively inexpensive, and although sometimes patients can't really tolerate it. The other thing you can try is to repair the diaphragmatic defect, and that typically would be for patients who are surgical candidates. Typically, those would be patients with the lower MELD scores. Typically, that would be done through a video assist thoracoscopic surgery, or VATS. They can either do mesh or suturing, but this is a procedure that does have a relatively high morbidity. So this is something that you should definitely be discussing with your thoracic surgeon and the patients to see if it's really worth it. Again, this would be for patients who are probably not going to be liver transplant candidates. What about removal of the fluid? Well, I've talked about repeated thoracentesis. This is something that can be done every couple of weeks if needed, although it can be a little risky, particularly if the INR is greater than 2 and the platelets are less than 50,000. And unlike ascites fluid, where you can remove pretty much all you can, my record I think is about 21 liters in one sitting. Only a limited amount of fluid can be removed at the chest at any time. Chest tubes are sometimes done, and but they're extremely high risk of infection and associated with a pretty increased mortality. So often we will get patients transferred into us from an outside hospital where the patient has presented with hepatic hydrothorax, and their first go-to move is to put in a chest tube. But we definitely do not want to put chest tubes in. And when we get those patients, our number one job once we admit the patient is to figure out a way to get the chest tube out. As I've mentioned, there are indwelling pleural catheters, which are tunneled and can allow for intermittent drainage, more like a Pleurodex catheter. But these have gained some traction, but we typically only use them for palliative care. And then, of course, in the past, people have done pleural venous shunts, like a Levine shunt or a Denver shunt. We used to do these, but the surgeon who used to do them for us hasn't been with us for quite some time, and I don't think I've requested a pleural venous shunt for a patient in probably more than 10 years. What about obliteration of the pleural space, particularly if TIPS is not possible? So you can do surgical pleurodesis. I mentioned VATS. Typical, the chemical irritant is talc. This is more of a mechanical way to obliterate the space. It can have success in up to 70%, but it also has a very high complication rate. As I've mentioned, liver transplant's the definitive therapy. And again, you should refer patients who develop hepatic hydrothorax at any MELD, not just when you think they meet minimal listing criteria. Very similar to when a patient develops ascites, even if they have a low MELD. And patients may qualify for MELD exemption points, at least in the US, particularly if they're undergoing weekly thoracentesis of at least a liter for 4 consecutive weeks. And fortunately, hepatic hydrothorax has no impact on post-liver transplant survival. So how do you then choose which strategy is right for your patient? So again, I've listed here the different types of categories, what you're actually doing, or the modality, and then the pros and cons of each. So again, we start with trying to reduce the production by using diet, diuretics, and potentially TIPS. The pros of diuretics and a diet are they're non-invasive, they're very inexpensive. TIPS is what we would call minimally invasive, but as we heard, it also has cost. The problem with diet is that there's a high rate of non-adherence. Diuretics require frequent blood tests to make sure the patient isn't developing hyponatremia or acute kidney injury, and TIPS can be associated with encephalopathy. Trying to prevent the transfer of the fluid using CPAP or surgical repair. Again, CPAP is easy, but there's very limited data. Surgical repair should be considered if TIPS is either not available or there's a contraindication, but it does have a lot of complications. Removal of the fluid is sort of quick. It's minimally invasive. You can put in a indwelling pleural catheter, such as a tunneled shunt, or you can even do a pleural venous shunt or Denver shunt. but these need to be repeated and they do have complications. VATS and pleurodesis can be considered when TIPS is contraindicated, although it is invasive and has surgical complications. And ultimately, transplant is going to be the definitive therapy, but there are wait times for organs. And then, of course, there's all the long-term complications of transplant, including need to take immune suppression. So just to try to summarize here, about 70 to 80% of TIPS, of hepatic hydrothorax are going to be on the right side. You need to get fluid studies looking, you want to see a fluid to serum total protein of less than 0.5, a fluid to serum LDH of less than 0.6, a fluid to a serum to fluid albumin of greater than 1.1, a total protein less than 2.5, and a pH of greater than 7.3. SBP can develop just like they can with ascites, and about a quarter of patients with hepatic hydrothorax will be refractory and require one of those other treatments that we reviewed. So now going back to this algorithm that I've mentioned before, again, we start with sodium restriction and diuretics. We ask early on, is the patient going to be a liver transplant candidate? If diet and medications fail, then we want to know if TIPS is going to be a possibility. However, if you think you can get the patient transplanted, particularly if they perhaps are going to have a living donor, then you might want to hold off and just continue periodic thoracentesis. And then if patient is not a TIPS candidate and won't be a transplant candidate, then you need to consider the more definitive options for surgery. So shown again, for people who like a more minimalistic slide, is this sort of older diagram from 2014. And again, just goes to show you that treatments really haven't changed all that much in the last 10 years. So going back to our case, patient gets started on diuretics, has a MELD now that's 15. The thoracentesis shows all those fluid parameters that I mentioned that define the patient as having a uncomplicated hepatic hydrothorax, and all the white count is 200. There's only 2% PMN, so it's not infected. Because the fluid has returned, the diuretics are increased to step 2. 80 milligrams of Lasix and 200 milligrams of spironolactone, and the low sodium diet is emphasized. Patient then undergoes a liver transplant evaluation. Patient comes back in 2 weeks, but now the sodium is 125 and the creatinine is bumped to 2.5 milligrams. Patient gets admitted and undergoes a repeat tap for comfort, and again, fortunately, shows no SBP. Because of the AKI and the hyponatremia, the diuretics are held. He's given a fluid restriction. We give him some albumin. Fluid then comes back. Echo is done, which you ordered initially, but it finally gets done. It shows no cancer, no portal vein thrombosis, and an EF of 65%. A TIPS is then placed. His HVPG was 20, is decreased down to 10. And he continues his liver transplant evaluation. But now, because he has a TIPS, he may not be eligible for those MELD exemption points, which were weekly taps of at least a liter for 4 consecutive weeks. So that might be an option, is to hold on the TIPS until you can get them MELD exemption points, and then get them listed if you can, and then do the TIPS if they're still eligible. So I'd just like to conclude that hepatic hydrothorax does occur in about 5 to 15% of those with cirrhosis. It's predominantly on the right side. Pleural fluid analysis is required for diagnosis. First-line therapy is a low-salt diet along with a diuretics used in a stepped-up fashion with careful monitoring for tolerance. Remember to refer your patient for liver transplant early if available, and if they fail or if their liver transplant is going to be more than 3 months, consider TIPS, particularly if their MELD is less than 18. If TIPS is not possible, you can consider the surgical options, or what we've been going to more and more are the Pluridex catheters, the tunnel catheters. And remember that hepatic hydrothorax is associated with a worse outcome than having similar cirrhosis with ascites. So I'll just stop there. And thank you for your attention.
Thank you very much, Professor Sterling. So now I would like to invite Professor Eder for the Q&A. So there are a lot of questions from the audience. I think let's start with Professor Sterling. So regarding management of hepatic hydrothorax, there is a question of when the diagnosis of spontaneous spectral empyema should be made.
So I
Yes.
think the diagnosis, typically that we would make the diagnosis every time I tap a patient. I look at the fluid. Fortunately, often you can just tell if it looks infected by the cloudiness of it. But typically, if I'm not physically looking at the fluid, I send it for cell count and diff each time. And if it looks cloudy, the second time I send it, I'll go ahead and I'll send all those other tests, the LDH and the protein and the albumin. I don't get those each and every time as long as the fluid looks good. I get them the first time, but I only get them on subsequent times if I think the patient has infected. So I guess the diagnosis would be made whenever you tap the patient. Typically in empyema, the patients are going to look sicker. They're going to have an elevated white count. They may have a fever. Certainly though, you suspect it in everybody.
Thank you. And
Thank you very much. May I actually thank you very much for your excellent talks, Professor Aital and Sterling. I would like to ask one thing. Actually, TIPS is one of the very important choice for the refractory ascites. And also, we know that the mainly we use the 10 millimeter diameter cover stent. But is there any comparative study related with the stent diameter of 8 or 10 millimeter used in the management of the refractory ascites?
Yeah. There are studies comparing, and they have got conflicting results. That's why I didn't really elaborate on it. As you saw, the best study is from randomized control trial I presented, 2017. That used 10 French and 10 millimeter stent, and then their target was to drop the portal pressure gradient below 12. But there is another paper in Journal of Clinical Gastroenterology and Hepatology, which argued that smaller stents are beneficial in ascites without increasing encephalopathy. But randomized control trial did not have encephalopathy as a problem. So there is a conflict. So if you feel that risk of encephalopathy is higher, say patient is over 70 but have no choice but to put in a TIPS, then I would really start with 8 millimeter and then see whether it responds.
I'm going back to
Thank you.
Professor Sterling. There was a question asking whether the bleedings of the hemorrhagic hydrothorax. One question is, recently we had hemorrhagic hydrothorax. Could it be as a result of prolonged INR? And another question is also whether when the hemorrhagic hepatic hydrothorax occurs, what could be managed?
Yeah, so I think it's like with ascites, it sort of depends on, certainly you can have a traumatic thoracentesis, even if, done properly and you go just, above the rib space. And so I always kind of wonder if it is a traumatic blood, which of course, if you start to see that, often, you should stop the procedure if you think it's going to be traumatic. I have seen hepatic hydrothorax. You could have blood. There could be a rupture if it's once you do get bleeding, particularly if you hit one of the intercostal vessels. Occasionally, or if you drop the patient's lung, if you cause a pneumothorax when trying to do the thoracentesis, of course, now you've caused even more problems. And occasionally that's where in those patients, the chest tube might be required. That really complicates everything because now you have a chest tube in a patient who you never wanted to put one in to begin with. And sometimes those might be patients that we might need to consider going to TIPS earlier on, even though they may not meet the full criteria, just to get the fluid to stop reaccumulating so we can eventually pull the chest tube. So I guess if I would answer the question is don't cause a traumatic tap, either by causing blood or dropping a lung if you have a choice. And I think that's why, at least in the United States, a lot of times these procedures are done by either the radiologist using ultrasound guidance or by our interventional pulmonary or IP team. Most hepatologists that I know no longer perform diagnostic or therapeutic thoracentesis just because they don't want to deal with the risks. And we have these other teams now available to us that are more than happy to do that. And I think the complication rate has dropped, but it doesn't go down to zero.
I just want to also to ask both of you that is there any limitations on the INR in terms of performing either paracentesis or thoracentesis?
No, not
Yeah.
for a paracentesis. I would say the only contraindication is disseminated intravascular coagulation. We don't really recommend routinely performing actually platelet count or coagulation profile before therapeutic paracentesis. So the risk of bleeding actually increases slightly if you do it without ultrasound guidance. Ultrasound guidance does not mean that you need to ask a radiologist to do it. I think most units now have got ultrasound. You can choose the site based on the depth of fluid, but the vessels, as long as you are in the right point, you will try and avoid vessels. So it's because you hit the vessel you bleed, not because you have got a coagulopathy. So there is no reason to really do them in the first place. But if you have got DIC, even without hitting a vessel, you will have a bleeding. And if you really look at the microvascular vasculature of the abdominal wall, you will never do a paracentesis because there is no place where there is no vessel. So you try and avoid big vessels, and then hopefully your anatomical landmarks will save you.
Yeah, I would agree.
Another question.
Yeah.
Sorry.
For us, it really depends on who's doing the tap. If it's the radiologist, they want platelets to be a certain amount and the INR to be under. But if it's a hepatologist trying to do the tap, then again, we don't have it. Sometimes we have to convince them by doing a TEG that the bleeding risk is not elevated.
Yeah. There is another question from Turkey, Professor Zeki Karasu, to Dr. Aital. What is the dose and duration of albumin in patients with ascites and creatinine more than 1?
Yeah, this is, basic recommendation is actually giving 1.5 grams at the time and then 1 gram per kg dry weight after, within about 48 hours. But there are 2 randomized controlled trials comparing the dose, and there is no difference in a lower dose where you just give 1 gram per kg. But these are really just 2 studies. They've got good number of people. One study drives all the results. So these are the things which we probably need to do in a systematic way in a large trial. So if you are, I would say, in a resource limited environment, keep in mind that lower dose may be sufficient if you can't afford it. We generally try and give the 1.5 at the time and then 1 gram within 48 hours. but we never really exceed more than 85 grams of total dose. So that's also important, that if you go over that, you have more likely to have complications. Does it answer the question? Yeah.
Yes. Again, Professor Zeki asking you if the patient with ascites and spontaneous bacterial peritonitis, what is your choice of antibiotic?
We give third generation cephalosporins and tazocine. Actually, tazocine is the first choice in Nottingham, for example. But most of the literature for EASL, the guidance is third generation cephalosporin. But I just kind of actually consciously avoided giving this advice. We were asked by the reviewers, we declined to give a guidance. This is like almost patronizing to assume that, you know, entire global population's rate of response and also antimicrobial resistance. So we should not really go by one antibiotic. I told you our choice in Nottingham is tazocine, but general choice in most of the literature is third generation cephalosporin. But you should have your own information and then give it.
And the same question to Professor Sterling regarding the roles of albumin in management of hepatic hydrothorax.
So there's a lot less literature. I'm not really sure of any controlled, I don't know of a controlled trial that you looked at albumin versus no albumin in hepatic hydrothorax. But remember, you're only removing typically a liter or two. So if you have ascites, a liter or two probably doesn't justify the use of albumin unless there's another reason to give it. So we typically don't give routine albumin if we're just removing a liter or two. I think if you're going to probably remove a lot of fluid, potentially at least 3 liters, which would be unusual to have that much fluid, but it's possible. I think there we might want to give, you know, some albumin. Typically the dose I give is 6 to 8 grams per liter removed, but again, we typically don't have to do it like we do with ascites. And our first choice of antibiotics, at least for most places in the United States, is a third generation cephalosporin. We tend to use ceftriaxone because it tends to get the 3 most common organisms that we see, which is strep, pneumo, Klebsiella, and E. coli. But certainly, you know, if the patient has had infections before, has been on antibiotics, we'll always would like to get a culture and hope it's positive so that we can know exactly what type of antibiotic we should use.
And it's a question from our steering committee, Professor Diana Payawa, regarding the roles of video assist thoracic surgery in the management of massive hepatic hydrothorax. I think you have mentioned a little bit, but could you?
Yeah, so I mean, I'm not a surgeon, but I have some of them on speed dial. So again, when we have a patient with hepatic hydrothorax and we're going to consider a surgical approach to try to close it or to you know, use talc, typically our thoracic surgeons will use a VATS related approach to that procedure.
Professor Edo, how about the roles of long-term albumin, like ANSWER trial?
I avoided this because it all is about one study and preventing refractory ascites, but I can go through that. I mean, this is a very well done long-term study where they gave albumin in people who did not have refractory ascites with the idea of reducing occurrence of refractory ascites. But at the same time, there was another study at the same time, which was done in a more severe people, also preventing, trying to reduce the all-cause mortality. And that study actually did not show any benefit, while ANSWER study showed substantial benefit. ANSWER study was done as an open label treatment with a standard of care, and people came to hospital to get a treatment. So simplest objection to answer study is that it wasn't randomized, it wasn't blinded, which means that you have got what is called a Hawthorne effect, which means that people got more than just albumin. When you come to hospital, they are seen by the doctors. It's a complex intervention. Doctors suggested things, they might have given advice. So that might have led to the benefit. Second is also that although these are patients who had very low level of, almost like a beginning of their ascites, they were chosen in an early stage of disease. They seem to have substantial mortality at the first 3 months or 4 months. So that remains unanswered in both groups, actually. So there was something looks a bit unusual in this study. So in summary, I would say that this trial should be done and repeated, because it is a good sample size study, and it is one study which has shown change in natural history of the disease, which hasn't been shown before. But the issues will be, question should be, it should be randomized, and if possible, there should be a comparable intervention on the control arm, and there should be a cost effectiveness study. And these are the things which need to be addressed for us to really take it as a standard treatment. That is what we recommended when we were doing the guidance.
Thank you. Back to our co-moderator, Professor Dr. Messi, please.
Yes, there is another question from Professor Karasu to Professor Sterling. What is the place of albumin in the treatment of hydrothorax?
So typically, again, I think there aren't any randomized trials that I know of that used it as prophylaxis. Again, because we're only removing a limited amount of fluid, a liter or a liter and a half each time, we typically do not give albumin. Now, we might want to go ahead and give albumin, particularly if the patient is severe hyponatremia or has an AKI, or if their serum albumin is low. But there are no specific guidelines on the use of albumin for the management of hepatic hydrothorax.
Thank you very much. Professor Tamwandi, is there any other question?
No, I think that's all of the questions that listed and asked during the session.
Okay.
So maybe we can. I'm not sure whether Professor Lin is here. Our president. No.
Professor Lin? No.
No, maybe you. I think it's time. I think this webinar we have learned a lot of practical things. I think this is going to be good for our fellow young doctors, for those who are practice in their clinic.
Thank you very much, Professor Eitel, Professor Sterling, and also other participants. It was really excellent webinar, and also Happy New Year to everyone. Thank you very much.
Thank you. Thank you.
Yes.
Bye-bye.
Bye-bye. Professor Yokosuka, how are you?
I'm fine, thank you. And very good.
I miss you very much.
Yeah, I often, see watch you. Anyway,
Are you coming?
yes, to go to Taipei.
Taipei, okay.
Yeah.
Is it possible for you to send your mobile telephone number?
Oh, yes. Can I say 090-1460-8130?
Just a minute.
Yeah.
Please repeat again.
090 1460 8103.
No, no. 0901460
Yeah.
and
8103.
8103.
03. Yeah.
Thank you very much.
Okay.
Everything is
to
going
meet
well,
you.
I think.
Yeah, yeah.
Good.
Good.
See you in
Bye-bye.
Taiwan.
Yeah.
Okay. Thank
Okay.
you very much.
See you.
Bye-bye.
Bye-bye.
Have a happy new year.
Same to you.
Thank you.
Okay.
Professor Kanda, are you online? No? It's okay. Thank you, Manoj. Bye-bye.